Hello everyone, and welcome to another stream of Pathophysiology. We're gonna jump right into chapter 37, our alterations of pulmonary function in children. Now we do have some very specific pages to read for this chapter, so I'm not going to be reading the entirety of the chapter, just the sections I truly need to cover. Again, my pages do not line up with what's posted here, so we will jump right into it. In regards to disorders of the upper airway. Pulmonary dysfunction can be categorized into disorders of either the upper airway or the lower airway. Signs of acute respiratory failure are the same regardless of etiology. These include the increased respiratory effort with retractions, cyanosis and pallor, agitation, decreased levels of consciousness, cardiovascular signs of tachycardia, mottled color and bradycardia, and the physiologic compromise reflected by the hemoglobin desaturation, hypoxemia, hypercarbia, and acidosis. So our upper airway obstruction. The crucial issue in the upper airway is patency. The most common cause of acute onset upper airway obstruction, or UAO, in children are infections, foreign body aspiration, angioedema, obstructive sleep apnea, and trauma. Chronic upper airway obstruction has many etiologies, including the congenital malformations affecting the airway, cartilaginous weakness, vocal cord paralysis, and subglottic stenosis. Chronic upper airway symptoms should prompt referral to a pediatric pulmonologist or an otolaryngologist because specialized diagnostic studies may be needed. And then there's a summary in this box. I'm not going to go into every single upper airway obstruction. You can take a look at it. And we'll move right through this. The site and nature of obstruction are often discernible. I'm actually going to, by accessing the noise or sounds associated with breathing, the quality of the voice or cry, and the presence of feeding difficulties. This assessment often can be made without even touching the child. Likewise, the severity of the problem often can be judged by visual observation or signs, including retractions, nasal flaring, gasping, or obstructed breaths. Anxiety, restlessness, or need to maintain a specific head or body position. Agitation should be regarded as a likely sign of hypoxemia or obstruction. In acute upper airway obstruction, increasing the child's anxiety by excessive physical examination can worsen the condition. The child should be kept as calm as possible. The clinician should never attempt a pharyngeal examination if there is any suspicion of epiglottis or retropharyngeal abscess, because this maneuver may precipitate acute obstruction of the airway. The snoring zone, the voice quality zone, the cough quality zone, inspiratory stridor, and expiratory V's all can be seen in the picture. The sounds of the child's breathing can provide key clues. A sonorous snoring noise is typical for nasopharyngeal obstruction, such as an adenotonsillar hypertrophy. A common sign of pediatric UAO is stridor, a harsh vibratory sound of variable pitch caused by turbulent flow through the partially obstructed airway. A diagnostic approach to stridor is outlined. Whether it is a present inspiration, expiration, or both reflects the site of the problem. In general, inspiratory stridor is generated with obstruction of the extrathoracic airway, which includes the supraglottic structures, the larynx, the subglottic space, and the upper trachea. Expiratory stridor or the monophonic V's may be generated by an obstruction in the intrathoracic airway. Biphasic stridor typically reflects obstruction at the glottis itself or a fixed rather than dynamic lesion in the subglottic space. Biphasic noise may sometimes mean abnormalities of both the extrathoracic and intrathoracic trachea. And here we have stridor. Is it severe? Yes or no? If it is, then it is a resuscitative effort required. If it's not severe, is the quality of stridor level obstructive? And then questions matter: is there a sonore snoring? Is there a muffled voice? A high-pitched inspiratory voice? Inspiratory and expiratory stridor, or just expiratory wheezing? Can tell us whether or not there are nasal problems, pharyngeal problems, laryngeal problems, tracheal problems, or bronchial problems. Is the baby or infant febrile or afebrile? Will also let us know if there are other issues. There's also questions in terms of is this acute or chronic, or if this is a symmetric breath sound or asymmetric. So diagnosing will tell us quite a bit too. Abnormalities of the voice or cry, weak or hoarse, suggests problem of the larynx, such as the vocal cord paralysis. Muffling of the voice, especially in acute conditions, suggests supralaryngeal obstruction, such as epiglottitis or retropharyngeal abscess. A pronounced cough may be an irritation syndrome, such as the produced by an aspirated foreign body, or may be a sign of a tracheal obstruction. The cough associated with croup or tracheal foreign body is usually harsh and barking. Airway obstruction occurs sooner in infants than in older children. Obviously, airway luminal size is smaller in accordance with smaller body size, but any decrease in luminal diameter will be much more significant. This is because airway resistance is proportional to the inverse of the fourth power of the radius. Thus, a decrease to half the original diameter increases resistance 16-fold. Furthermore, an infant's cartilaginous structure are more collapsible, thus are more prone to contributing to upper airway obstruction. Infections of the upper airway are common in children. Some have the potential to cause life-threatening emergencies. The recognition and rapid evaluation of these problems are crucial pediatric care skills. So we can have acute laryngotracheobronchitis or croup, and it's usually a gradual onset, but it is viral. And the pathophysiology is the inflammation of the vocal cords. Classic stuff for always having a PDF. There are portions that are missing. Great. Acute tracheitis is between the ages of 1 to 12, abrupt or following viral illness, usually a Streptococcus aureus or a methicillin-resistant S. aureus, Haemophilus influenza and group A, where there's an inflammation of the trachea. Epiglottitis, 2 to 6-year-olds, it's abrupt, it's H. influenzae or group A streptococci. Again, that inflammation of the supraglottic structures. The retropharyngeal abscess, anyone older than 6, it's usually gradual, has a couple different causes: S. aureus, MRSA, Streptococcus pyogenes, group A beta hemolytic streptococci, and polymicrobial. And there's an abscess in the posterior pharyngeal wall. And then the peritonsillar abscess, usually in 9-year-olds and older, may be abrupt by S. pyogenes and S. aureus. Again, there is that abscess within or around a tonsil. So croup. Illness includes viral croup, laryngotracheitis, recurrent croup, spasmodic croup, laryngotracheobronchitis, and laryngotracheobronchopneumonitis. Viral and recurrent croup are the most common. Diphtheria can be considered a croup illness, but is now rare because of vaccinations. Croup illnesses are characterized by infection and obstruction of the upper airway. Recurrent croup, a spasmodic croup, also described as atypical croup, is 2 or more episodes of croup with symptoms similar to croup, except that it recurs without symptoms of respiratory tract infection. It often resolves as quickly as it develops and usually occurs in older children. The etiology is unknown, but in some cases it is associated with an underlying congenital obstruction or airway narrowing. Laryngomalacia or tracheomalacia. There also may be other associated illnesses such as gastroesophageal reflux disease or asthma. Acute laryngotracheitis croup most commonly occurs in children from 6 months to 5 years of age, with a peak incidence of 2 years of age. The pathophysiology of viral croup is caused primarily by subglottic edema from the infection. The mucous membranes of the larynx are tightly adherent to the underlying cartilage, whereas those of the subglottic space are looser and thus allow accumulation of mucosal and submucosal edema. Furthermore, the cricoid cartilage is structurally the narrowest point of the airway, making edema in this area critical. Increased resistance to the airway leads to increased work of breathing, which generates more negative intrathoracic pressure, which in turn may exacerbate dynamic collapse of the upper airway. So if we're looking at the epiglottis, the false chords, the true chords, the subglottic tissue, and the trachea. That right-hand side of the picture shows that narrowing and obstruction from edema caused by croup. So we have an inflammation and edema, then the upper airway becomes obstructed due to that edema. Now that obstruction has an increased resistance to airflow, that increased intrathoracic negative pressure builds, the collapse of the upper airway happens, and we have respiratory failure. Clinical manifestations. Typically, there is a prodrome of rhinorrhea or sore throat and low-grade fever for a few days. The child develops these characteristics: harsh, seal-like barking cough, hoarse voice, and inspiratory stridor. Most cases are mild and resolve spontaneously. After several more days, occasionally, however, upper airway obstruction becomes severe and requires urgent management. So our evaluation and treatment. The degree of symptoms determines the level of treatment. Most children have a barking cough and viral symptoms and may need no specific treatment. However, the presence of stridor, especially at rest, retractions, or agitation suggests a sicker child. The tool most often used for estimating croup severity is the Vesely-Croup score, which provides a cumulative score for a degree of stridor, retractions, air entry, cyanosis, dyspnea, and level of consciousness in the child. The degree of seriousness of croup also is classified as mild, moderate, and severe. Most children with croup require no treatment. Inhalation of humidified air does not improve symptoms in mild to moderate croup. Glucocorticoids, either injected or oral, dexamethasone, or nebulized budesonide, have been shown to improve symptoms within 6 hours. The use of nebulized racemic epinephrine improves outcomes with moderate to severe croup. Epinephrine stimulates alpha and beta adrenergic receptors and is thought to decrease airway secretions and mucosal edema. It is temporizing measure until concomitantly given corticosteroids begin to take effect. Thus, children who are given nebulized epinephrine should be closely observed for 2 to 3 hours to ensure that they will remain stable. Oxygen should be administered. Heliox, a helium-oxygen mixture of 80-20 or 70-30, may be used for severe cases of croup, although there is a lack of scientific evidence to establish use in routine clinical practice. In rare cases, croup and recurrent croup may require placement of an endotracheal tube. Children with recurrent croup require evaluation for anatomic abnormalities and the presence of associated disease. Your acute epiglottitis is historically acute epiglottitis, which is caused by a Haemophilus influenza type B. Since the advent of Hib immunization, the overall incidence of acute epiglottitis in children has decreased significantly. However, up to 25% of epiglottitis cases are still caused by HIB. Current pediatric cases usually represent vaccine failure or are caused by other pathogens. Infants less than 1 year of age are at greater risk. Non-infectious causes include trauma from foreign body, inhalation, and chemical burns. So the pathophysiology, the epiglottis arises from the posterior tongue base and covers the laryngeal inlet during swallowing. It has a rich blood and lymphatic circulation. Bacterial invasion of the mucosa and associated inflammation lead to the rapid development of edema, causing severe life-threatening obstruction of the upper airway. So our clinical manifestations, the classic form of the disease, a child between 2 and 6 years of age suddenly develops a high fever, irritable, sore throat, a hot potato voice, inspiratory stridor, and severe respiratory distress. The child appears ill and classically will adopt a forward-leaning position, a tripod position, with drooling or dysphagia, inability to swallow. The examination of the throat may trigger laryngospasm and cause respiratory collapse. Death may occur in a few hours. Pneumonia, cervical lymph node inflammation, otitis, and rarely meningitis or septic arthritis may occur during the course of epiglottitis. So what's our evaluation? Well, acute epiglottitis is a life-threatening emergency. The essentials are recognizing the presence of the disease, being careful not to disturb the child, which could worsen the obstruction, and securing the airway. Examination of the throat should not be attempted because it may trigger laryngospasm and cause respiratory collapse. With severe airway obstruction, the airway is secured with an endotracheal intubation and anesthesia. Subsequent culture of the airway is obtained and IV broad-spectrum antibiotics are administered promptly. Therapy is re-evaluated after culture results return. Corticosteroids are also generally used in treatment regimens. Resolution with treatment is usually rapid. When the HIV epiglottitis is diagnosed, the American Academy of Pediatrics recommends that the post-exposure prophylaxis with rifampin be administered to household contacts of the infected child if they have not been fully vaccinated or are immunocompromised. Rifampin is given once daily for 4 days and eradicates H. influenza type B in approximately 95% of carriers. Your tonsillar infections are occasionally severe enough to cause upper airway obstruction. As with other infections of the upper airway, the incidence of tonsillitis secondary to group A beta hemolytic streptococci and methicillin-resistant Staphylococcus aureus has risen in the past 15 years. Significant swelling of the tonsils and pharynx occurs, and a tenacious membrane may cover the mucosa. Upper airway obstruction because of tonsillitis is a well-known complication of the infectious mononucleosis, especially in a young child. The development of UAO in tonsillar infections requires the administration of appropriately selected antibiotics and the use of corticosteroids. Some children with recurrent tonsillitis benefit from adenotonsillectomy. Tonsillitis may be complicated by formation of a tonsillar abscess, which can further contribute to airway obstruction. Peritonsillar abscess is usually unilateral and is most often a complication of acute tonsillitis. The most common causative microorganism is GABHS, or that group A beta hemolytic streptococci. Symptoms in children include fever, sore throat, dysphagia, trismus, pooling of saliva, and a muffled voice. Peritonsillar bulging and a cervical adenopathy on the same side are usually visible. The abscess must be drained and the child given antibiotics. Death can occur from spontaneous abscess rupture with aspiration of airway obstruction. Bacterial tracheitis, or pseudomembranous croup, is the most common potential life-threatening upper airway infection in children. It is most often caused by S. aureus, including methicillin-resistant MRSA strains, H. influenza, the GABHS, Streptococcus pyogenes, or Moraxilla catarrhalis virus. A fungus is more likely to be seen as the source of tracheitis in immunocompromised children. The presence of airway edema and copious purulent secretions leads to airway obstruction that can be worsened by the formation of a tracheal pseudomembrane and mucosal sloughing. Increased morbidity can occur because of a respiratory and cardiopulmonary arrest, respiratory failure, pneumonia, septic shock, toxic shock syndrome, acute respiratory distress syndrome, and multiple organ dysfunction syndrome. The onset of symptoms may be sudden or may be preceded by a pre-existing viral upper respiratory tract infection or croup. The acute clinical presentation frequently includes tachypnea, stridor, a hoarse voice, fever, cough, and/or an increased secretion from the mouth and nose. There may be evidence of a concurrent infection, such as a sinusitis, otitis, pneumonia, or pharyngitis. Management requires the rapid administration of broad-spectrum antibiotics via IV and an endotracheal intubation in order to prevent airway obstruction. The retropharyngeal abscess can be caused by aerobic, anaerobic, or polymicrobial infections. There has been an increase in GABHS strains associated with this condition, and the emergence of MRSA as an offending microorganism is increasingly noted. Retropharyngeal abscess usually occurs more commonly in children about 4 years of age and as a consequence of either nasopharyngeal infection or penetrating local injury. Clinical signs include fever, dysphagia, drooling, stridor, respiratory distress, and neck pain. This condition requires emergency treatment with IV antibiotics targeted at suspected microorganisms, and sometimes incision and drainage. So we're going to jump right past the aspiration of foreign bodies and jump to page 3860, where we will continue on our section. So I'm not sure what page that is in the book, but it would be bronchopulmonary dysplasia. Bronchopulmonary dysplasia, or BPD, also known as a chronic lung disease of prematurity, is a chronic inflammatory lung disease associated with arrest, pulmonary development, and a need for a supplemental oxygen. It is the major cause of pulmonary disease in infants and is associated with premature birth, usually before 28 weeks of gestation and a birth weight less than 150 grams. Your SDD, RDS, your perinatal supplemental oxygen, and positive pressure ventilation. Annually in the US, approximately 10,000 to 15,000 infants are affected, including about 50% of infants weighing less than 1,000 grams. Up to 30% of very low and extremely low birth weight infants develop BDP. The widespread use of antenatal glucocorticoids, postnatal surfactant, and NCPAP has lessened the incidence and severity of SDD, and thus also reduced the incidence of BPD. Surprisingly, some of the tiny infants who develop BPD have shown few to no clinical signs of SDD, RDS, at birth, or have initially received only low levels of supplemental oxygen or ventilatory support for apnea. The presence of antenatal chorioamnionitis, your preeclampsia, inflammation, and postnatal sepsis, patent ductus arteriosus, hyperoxia, and genetic susceptibility confers additive risk of developing BPD. Numerous biomarkers associated with immunity, inflammation, and oxidative stress also have been identified and are being used to develop risk factors and guidelines for diagnosis and treatment. Your BPD is a multi-system condition and is associated with developmental disorders in other systems, such as growth retardation, pulmonary hypertension, neurodevelopmental delays, such as cerebral palsy, hearing defects, and retinopathy of prematurity. Your pathophysiology, lung immaturity and inflammation contribute to the development of BPD. In preterm infants born at less than 28 weeks of gestation, the fetal lung is in the canalicular stage of development. That's 16 to 28 weeks, a critical period during which type 2 epithelial cells appear. Capillaries grow into the future distal alveolar regions, and the interstitium begins to condense. Ultimately, the alveoli must have a very thin interface between the airspace and the capillary for appropriate gas exchange. The extensive network of alveoli develops by septation within the terminal respiratory unit, beginning in the succular stage. Starting at approximately 26 to 28 weeks, the alveoli are vulnerable to inflammation and impaired growth during this stage. Before the widespread use of surfactant therapy, BPD was a disease characterized by airway injury, inflammation, and parenchymal fibrosis. Now, after the initiation of surfactant therapy, what is called new BPD is most often a form of arrested lung development with poor formation of alveolar architecture. Alveoli are large and fewer in number, thereby presenting decreased surface area for gas exchange. There is abnormal vascular endothelial growth factor that results in hypoplastic pulmonary capillary development and mild fibrosis, accompanied by persistent inflammation contributing to ventilation-perfusion mismatch, pulmonary hypertension, and lasting pulmonary vascular disease. Levels of pro-inflammatory cytokines such as tumor necrosis factor alpha, interleukin 1 beta, interleukin 6, and interleukin 8 are elevated in the amniotic fluid or tracheal aspirates, or both, of preterm infants who later develop BPD. Inflammation invites neutrophils and macrophages to release reactive oxygen species, that RAS, and proteolytic enzymes, initiating oxidative and immune injury. The predominant mediators of the new BPD are profibrotic angiogenic cytokines, which contribute to pulmonary hypertension. And then a figure shows the pathophysiology. So if we have a premature respiratory failure, mechanical ventilation, that mechanical ventilation, excessive tidal volume, decreased lung capacity. The volutrauma, you have an increased inspiratory oxygen deficient antioxidant system, nutritional deficiencies or oxygen toxicity, or we have the pre-postnatal infection, neutrophil activation, which leads to inflammation, and the patent ductus arteriosus, excessive fluid intake, increased pulmonary blood flow, lung edema, all of which can contribute to the acute lung injury inflammatory response via cytokine activation. So what are our clinical manifestations of BPD? Include the need for supplemental oxygens at 36 weeks of postmenstrual age, which is also known as the gestational age, the time elapsed between the first day and the last normal menstrual period and the day of birth, and for the last 28 days after birth. It also details graded severity dependent on required respiratory support at term, divided into mild, moderate, and severe based on oxygen requirements and ventilatory needs. Clinically, the infant exhibits hypoxemia caused by a ventilation-perfusion mismatch and diffusion defects. Work of breathing is elevated, resulting in hypercapnia. The ability to feed may be impaired, intermittent bronchospasm with wheezing, mucus plugging, and pulmonary hypertension characterizes the clinical course of the most severely affected babies. Of the most severely affected infants, dusky spells may occur with agitation, feeding, or gastroesophageal reflux. Infants with mild BPD may demonstrate only mild tachypnea and difficulty handling respiratory tract infections. So our evaluation and treatment include infants with severe BPD, require prolonged assisted ventilation, prevention of lung damage with non-invasive respiratory support, or early nasal intermittent CPAP, or both, is used in clinical situations when permitted. When compared to mechanical ventilation, the use of CPAP has resulted in fewer days of oxygen and ventilator requirements by reducing the amount of lung injury. Additionally, oxygen supplementation at lower than previously accepted values is a means to reduce oxidant injury to the lungs and retinal vasculature. Diuretics are used to control pulmonary edema, bronchodilators reduce airway resistance, inhaled corticosteroids improve the rate of extubation and reduce the time that mechanical ventilation is required. Prophylactic caffeine citrate is used to prevent apnea and for neuroprotection. Supplementation with vitamin A provides antioxidant protection and stimulates lung growth and surfactant production. New treatments are under consideration. Careful nutritional and fluid and electrolyte support is routinely used and has resulted with improved outcomes. Your respiratory tract infections are common in children and are a frequent cause of emergency department visits and hospitalizations. Clinical presentation, age of the child, season of the year, and environmental exposure can often provide clues to the etiologic event, even when the agent cannot be proven. So, what does that mean about your bronchiolitis? Well, bronchiolitis is a common viral induced respiratory tract infection of the small airway that occurs almost exclusively in infants and young toddlers. There is a distinct regional difference in the United States depending on the geographic variation in the viral season. The most common associated pathogen is the respiratory RSV, but bronchiolitis also may be associated with the rhinovirus, adenovirus, influenza, parainfluenza virus, human metapneumovirus, and Boca virus. There are distinct regional differences in the US depending on the variation in the viral season based on geography. Healthy infants usually make a full recovery from RSV bronchiolitis, but infants who are premature or who have an underlying BPD, heart disease, or immune deficiency may have a much more severe or even deadly course. Their respiratory systems are immature, and maternal immunoglobulins do not protect against RSV infections. Bronchiolitis has been linked to an increased risk for asthma later in children, particularly in those with a family history of asthma. So, our pathophysiology. A viral infection causes inflammation and necrosis of the bronchial epithelium with destruction of ciliated epithelial cells. There is infiltration with lymphocytes around the bronchioles and a cell-mediated hypersensitivity to viral antigens with release of lymphokines, causing inflammation, as well as activation of eosinophils, neutrophils, and monocytes. The submucosa becomes edematous, the cellular debris and fibrin from plugs within the bronchioles, edema of the bronchiolar wall, accumulation of mucus and cellular debris, and possible bronchospasm, narrow or occlude many peripheral airways. Airway obstruction leads to atelectasis and uneven ventilation, leads to the ventilation-perfusion mismatch, and hypoxemia. Airway narrowing causes obstruction of airflow that is worse with expiration. This leads to air trapping, hyperinflation, and an increase in FRC. Airway resistance and hyperinflation result in decreased lung compliance and increased work of breathing, and may cause hypercapnia in severe cases. Your clinical manifestations, symptoms usually begin with significant rhinorrhea, followed by a tight, dry cough over the next several days, along with systemic signs of decreased appetite, lethargy, and fever. Infants may have tachypnea, expiratory wheezing, cough, rhinorrhea, mild fever, varying degrees of respiratory distress, and abnormal oscillatory findings in the chest. Wheezing is the most common, but rheals or rhonchi also may be present. Chest radiographs often show hyperexpanded lungs, patchy or peribronchial infiltrates, and atelectasis of the right upper lobe. With overexpansion of the lungs, the diaphragm is flattened, causing downward displacement of the liver and spleen. Abdominal distension results from air swallowing. Very young infants may present with severe apnea before lowering respiratory tract symptoms appear, and these apneas frequently require mechanical ventilation. Many children also may present with conjunctivitis or otitis media. So, what is our evaluation and treatment? Well, guidelines of the American Academy of Pediatrics are available for evaluation. treatment and prevention of bronchiolitis. Diagnosis of bronchiolitis is made by review of history, signs and symptoms, rhinitis, cough, wheezing, crackles, chest retractions, and/or hyperinflation and tachypnea. Lab studies and radiologic or ultrasound examination are not routinely performed. Nasal washings, swabbings may be tested for specific viral agents, such as RSV. RSV swabs are positive in 70% of cases of bronchiolitis. Treatment is determined by the severity of the disease and the age of the child. Most cases are mild and require no specific treatment, and affected children may be monitored as outpatients with supportive care. In more severe cases, supplemental oxygen with high-flow nasal cannula and increased hydration are commonly used. Nebulized 3% hypertonic saline has shown heterogeneous outcomes. Continuous positive airway pressure, or CPAP, increases positive and expiratory pressure. PEEP and warm humidified oxygen helps to overcome airway resistance. Preventative treatment or prophylaxis with RSV specific options include immunotherapy with palivizumab and RSV specific recombinant monoclonal antibody, although it is costly. Other preventative measures include use of hand washing and alcohol-based decontamination, prevention of exposure to tobacco smoke, and promotion of infant breastfeeding. No licensed vaccine is currently available to protect against RSV. Pneumonia. Pneumonia is infection and inflammation in the terminal airways and alveoli. Community-acquired pneumonia is a major cause of morbidity and mortality in children, particularly in developing countries. The incidence of viral and bacterial pneumonias varies according to age, time of year, and geographic location. The most common agents are viruses, followed by bacteria and atypical microorganisms, or mycoplasma. Clinical symptoms often do not differentiate viral from bacterial or atypical pneumonia. Risk factors for developing your community-acquired pneumonia include age younger than 2 years, overcrowded living conditions, winter season, recent antibiotic treatment, attendance at a daycare center, and passive smoke exposure. Nutritional status, age, and underlying disease process influence morbidity and mortality. So viral pneumonia is 2 to 3 times more likely in children than in adults, and incidence generally follows this seasonal pattern. Bacterial co-infections are common. The most common cause in infants and young children is respiratory RSV. A number of other viruses are important, including parainfluenza, influenza, human rhinovirus, human metapneumovirus, adenoviruses, and mycoplasma pneumoniae. Acquisition of viruses is by direct contact, droplet transmission, or aerosol exposure. There is initial destruction of the ciliated epithelium of the distal airway, with sloughing of cellular material. A mononuclear predominant inflammatory response initially occurs in the interstitium and may later involve the alveoli. It is often difficult to determine whether the pneumonia is viral or bacterial early in the course of the disease. The clinical presentation of viral pneumonia often consists of cough and no fever, and the white blood count is often normal. In bacterial pneumonia, the degree of elevated temperature, absolute neutrophil count, and percent of bands are consistent higher than in those of the viral etiology. Your diagnosis of viral etiology requires lab confirmation, your immunofluorescent test. Antiviral therapy may prevent development of the influenza-associated CAP. Development of safe agents to treat and prevent viral pneumonias continues to be a priority, as is development of more effective vaccines. Bacterial pneumonia beyond the neonatal period is most common the result of infection with Streptococcus pneumonia. It is the predominant bacteria isolated from the bacterial CAP in children. Other causative microorganisms include S. aureus and atypical bacteria, Mycoplasma pneumonia, and Chlamydia pneumoniae. Childhood immunizations with polyvariant pneumococcal conjugate vaccine is recommended to decrease the incidence of pneumococcal pneumonia in children younger than 2 of age. Haemophilus influenza pneumonia has become rare because of the widespread immunization. Here we have some viral pneumonias and pneumococcal pneumonias and its causal agent, the age, onset, signs and symptoms. But again, a portion that is just unfortunately written off. So, bacterial pneumonia usually begins with aspiration of one's own nasopharyngeal bacteria. A preceding viral infection sometimes sets the stage for bacterial infection by causing a damaged epithelium, reduced mucociliary clearance in the trachea and major bronchi, and a reduced immune response. Once in the alveolar region, bacterial encounter local host defenses such as antibodies, complement phagocytes, and cytokines that prepare bacteria for ingestion by alveolar macrophages. Alveolar macrophages recognize bacteria with their surface receptors and phagocytose them. If these mechanisms fail, macrophages will release numerous inflammatory cytokines, neutrophils will be recruited, and an intense cytokine-mediated inflammation will ensue. Vascular engorgement, edema, and a fibrinopurulent exudate with tissue damage occurs. Alveolar filling precludes gas exchange and, if extensive, can lead to respiratory failure. If sepsis occurs at the same time, shock and end-organ hypoperfusion will cause metabolic acidosis. Staphylococcal and group A streptococcal pneumonia can be particularly fulminant and necrotizing, with a high incidence of accompanying empyema, pneumatoceles, and sepsis. Empyema is associated with pneumococcal infections and antibiotic-resistant microorganisms. The clinical presentation of bacterial pneumonia, particularly pneumococcal, may include a preceding viral illness, followed by fever with chills and rigors, shortness of breath, and an increasing productive cough. Occasionally, there is blood streaking of the sputum. Respiratory rate and oxygen saturation are important clinical indicators. Auscultation usually reveals such abnormalities as crackles or decreased breath sounds. Other less specific findings may include malaise, emesis, abdominal pain, and chest pain. Chest films will usually present with a lobar pattern in older children and adolescents, but may appear patchier with bronchopneumatic pattern in younger children. Atypical pneumonia, your mycoplasma pneumonia, or your chlamydophila pneumonia is a most common cause of CAP for school-age children and young adults. Chlamydophila pneumonia is clinically indistinguishable form and is typically grouped with a mycoplasma as atypical pneumonia. Transmission is person to person with a 2 to 3 week incubation period. Mycoplasma is known to cause a wide spectrum of disease and has more extensive complications than previously recognized. Studies reveal a macrolide-resistant mycoplasma pneumonia is seen increasingly in infants and younger children. Children experiencing recurrent respiratory tract infections often have been found to be infected with atypical bacteria. Mycoplasma microorganisms lack cell walls but have a limiting membrane and a specialized tip for attaching to ciliated respiratory epithelial cells. Local sloughing of cells occurs, peribronchial lymphocytic infiltration develops, along with neutrophil recruitment to the airway lumen. The pattern resembles bronchitis or bronchopneumonia. Onset of symptoms is usually gradual, resembling a typical upper respiratory tract infection with low-grade fever and a prominent cough. There may have been accompanying wheezing, sore throat, myalgia, and headache. Cases are not usually clinically severe, and full recovery should be expected without complications. When complications do occur, they can include bronchopneumonia, parapneumatic effusions, and necrotizing pneumonitis. Your evaluation and treatment. Your guidelines have been developed to improve and aid assessment and management of pediatric pneumonia. Diagnosis of pneumonia is based on clinical and laboratory findings. The etiologic agent can sometimes be inferred from the age of the child and clinical scenario. Chest X-ray in bacterial pneumonia initially shows an alveolar infiltrate and later reveals a segmental or Lombard disease. A viral infection is more likely to be associated with an interstitial pattern. Identifying etiologic pathogens can be very difficult in children, especially because there is often overlap between bacterial and viral pathogens. Biomarkers facilitate more rapid diagnosis, and procalcitonin is most specific to bacterial infection and can guide antibiotic therapy. A highly sensitive C-reactive protein is less specific, and its level is elevated in both viral and bacterial infections. Other lab tests may be helpful include a white cell granulocyte count or erythrocyte sedimentation rate, or ESR, but do not indicate a specific etiology. Several microbiologic tests are available, such as polymerase chain reaction, PCR, and nucleic acid amplification tests, NAATs. Some pneumonias may be treated on an outpatient basis. However, some children require oxygen supplementation and occasionally assisted ventilation. This is particularly true with infants who have a viral interstitial pneumonia, like that caused by RSV. In addition, adequate hydration, nutrition, and supportive pulmonary therapy are required to reduce the duration and severity of the illness. Many infants are markedly tachypnic and unable to coordinate their breathing, with swallowing such that they may require enteral feeding. Aspiration is always a risk with infants in respiratory distress. Appropriate antibiotic administration for bacterial pneumonias is dependent on age and severity assessment. Local patterns of drugs resistance must be considered when choosing appropriate antibiotics. Pneumococcal and mycoplasmal pneumonias present some unique treatment obstacles and may need a multifaceted approach to care, including vaccine antigens and immunoadjuvant therapies. Treatment of mycoplasma pneumonia with antibiotics is controversial. Children should be vaccinated against influenza and pneumococcus. Your aspiration pneumonitis is caused by a foreign substance, such as meconium, food, secretion, your saliva and gastric secretions, or environmental compounds entering the lung and causing inflammation of lung tissue. The aspiration of meconium from amniotic fluid can occur at birth. Meconium contains bile, salts, and other constituents from the fetal intestinal tract that cause inflammation. Neurologically compromised children or children with chronic lung disease may have chronic pulmonary aspiration, or CPA, chronic pulmonary aspiration, which can cause progressive lung disease, bronchiectasis, and respiratory failure. This is the leading cause of death in children who are neurologically compromised because of failure of protective reflexes and difficulty swallowing. Children undergoing sedation or administration of an anesthetic also may aspirate oral secretions contaminated with anaerobic bacteria or stomach contents. The severity of lung injury after an aspiration incident is determined by the volume of material aspirated, the pH of the aspirated material, and the presence of pathogenic bacteria. Very low pH or very high pH causes a significant inflammatory response with hydrocarbon ingestion. Lung injury is determined by the volatility and viscosity of the aspirated substance. A low viscosity substance such as gasoline or lighter fluid is the most toxic. High viscosity hydrocarbons such as petroleum jelly or mineral oil are much less likely to cause pneumonitis. Treatment for aspiration pneumonitis depends on the material aspirated, but generally can include broad-spectrum antibiotics with failure to improve after 48 hours. Children with CPA and a large amount of upper respiratory tract infections may benefit from a salivary gland injection of botulinum toxin A to suppress secretions. Bronchiolitis obliterans, or BO, is a fibrotic obstruction of the respiratory bronchioles and alveolar ducts secondary to intense inflammation. It is relatively rare in children. There are two types are noted in this literature, your proliferative and your constrictive, or obstructive, with the latter being the more common. Bronchiolitis obliterans most often occurs as a sequela of a severe viral pulmonary infection. Your adenovirus, your influenza, your whooping cough, or measles. Other cases may be secondary to parainfluenza, RSV, HIV, or M. pneumonia infection. It may occur after allograft transplantation, a lung, heart, lung, and bone marrow, as a manifestation of graft versus host disease. Your bronchiolitis obliterans, BO, also is associated with collagen vascular disease, toxic fume inhalation, chronic hypersensitivity pneumonitis, Crohn's disease, and Stevens-Johnson syndrome. Cough, respiratory distress, and cyanosis initially occur, followed by a brief period of improvement. The progression of disease is then reflected by increased tachypnea, sputum production, crackles, wheezing, increased anterior and posterior diameter, and hypoxemia. There is no specific treatment for BO, bronchiolitis obliterans. And because it is so rare, there have been no randomized clinical trials. Therapeutic options include inhaled corticosteroids, bronchodilators, and antibiotics, oxygen supplementation. Mechanical ventilation may contribute to the progression of the disease. Use of antiviral agents may be warranted in managing those with viral infections. For transplant recipients, augmentation of immunosuppressive therapies without increasing risk for infection and treatment with anti-inflammatory agents are shown promise in reducing airway inflammation, thus improving pulmonary function. Clinical progression can be quite variable depending on the predisposing condition. Some children experience partial recovery, whereas others follow a course of steady decline in lung function. Lung transplantation may be considered. Asthma is a chronic inflammatory disease characterized by bronchial hyperreactivity and reversible airflow obstruction, usually in response to an allergen. It is the most prevalent chronic disease in childhood, affecting about 8.4% of children between birth and 17 years of age, with prevalence on the rise. Populations most affected include Black and Puerto Rican children, those below 100% of poverty status. Children or childhood asthma and its severity result from a complex interaction between genetic susceptibility and environmental factors. Genetic studies have led to the identification of many candidate genes or chromosomal regions that are associated with asthma. Included in the long list of asthma-associated genes are those that code for increased levels of immune and inflammatory mediators, your IL-4, IL-5, IL-6, IL-13, and IgE and leukotrienes, adrenergic receptors, nitric oxide, and transmembrane proteins in the endoplasmic reticulum. Various genotypes are associated with multiple phenotypes of asthma, including early onset mild allergic asthma, asthma with severe exacerbations, later onset asthma associated with obesity, atopic or non-atopic asthma, eosinophilic or non-eosinophilic asthma, asthma associated with aspirin sensitivity or insensitivity, and asthma dependent on resistant to corticosteroids. Linking specific genes to specific asthma phenotypes is leading to targeted therapies and personalized approaches to asthma treatment. Important environmental risk factors include early exposure to allergens, your air pollution, dust mites, mold, cockroach allergens, and tobacco smoke. Respiratory tract infections, gastroesophageal reflux, preterm birth, and childhood obesity. Additional confounding variables that affect disparity in asthma, morbidity, and therapy are social stress in the home, your violence and depressed housing conditions, lack of health insurance, poor access to asthma specialists, inappropriate utilization of healthcare resources, and inadequate medical care. Vitamin D insufficiency may be a risk factor for wheezing in children because vitamin D suppresses Th2-mediated allergic disease, suppresses inflammatory Th17 cells, inhibits IgE expression in B cells, and is most important for lung development, and suppresses infection. Epigenetic mechanisms of asthma pathogenesis are being evaluated. Individual risk factors may overlap and vary in strength of association. The hygiene hypothesis proposes that infants and children who are exposed to a highly hygienic environment, who receive vaccination to prevent certain infection, or are treated with antibiotics lack adequate exposure to common pathogens and therefore do not achieve balanced immune responses as they mature. Consequently, this increases their risk for Th2 predominant allergic disease. Early exposure to microbial products also may promote a microbiome that promotes Th1 immunity necessary to balance Th2 immune responses. Your pathophysiology of asthma in children is similar to that for adults, and is described in Chapter 36 under Asthma under Obstructive Pulmonary Disease. Early onset allergic asthma is initiated by a type of 1 hypersensitivity reaction primarily mediated by Th2 lymphocytes, whose cytokines activate mast cells and eosinophils, increase leukocyte synthesis, and enhance B cell IgE production. As in adults, inflammation, bronchospasm, and mucus production in the airway leads both to ventilation-perfusion mismatch with hypoxemia and to expiratory airway obstruction with air trapping and increased work of breathing. In young children, airway obstruction can be more severe because of the smaller diameter in their airways. Your clinical manifestations of an acute asthma attack include coughing, wheezing, and shortness of breath. Expiratory wheezing is often described as high-pitched and musical, along with prolongation of the expiratory phase of the respiratory cycle. Breath sounds may become faint when air movement is poor. The child may speak in clipped sentences or not at all because of dyspnea. Respiratory and heart rates are elevated. Nasal flaring and accessory muscle use are evident, with retractions in the substernal, subcostal, intercostal, suprasternal, or sternocleidomastoid areas. Infants may appear to be head bobbing because of the sternocleidomastoid muscle use. Pulsus paradoxus, a decrease in systolic blood pressure of more than 10 milligrams of mercury during inspiration may be present. The child may appear anxious or diaphoretic, important signs of respiratory compromise. About 70% to 80% of acute wheezing episodes are associated with viral respiratory tract infections. As a result, there may be signs of a preceding upper respiratory tract infection, such as rhinorrhea or a low-grade fever. The most common of these RSV in infants and toddlers younger than 2 years of age, and rhinovirus in older children. Findings in chronic asthma may include hyperinflation of the thorax, a barrel chest, or pectus excavatum. Clubbing should not be seen in those with asthma and, if present, should trigger evaluation for other conditions, such as cystic fibrosis. Exercise intolerance may indicate underlying asthma. Your evaluation and treatment. Well, currently asthma cannot be prevented or cured, but it can be controlled. Asthma is often underdiagnosed and untreated, especially in preschool-aged children, because asthma symptoms overlap with other respiratory illness, such as bronchitis and upper respiratory tract infections. Diagnosis is based on episodes of wheezing, as well as a variety of risk factors including parental history of asthma, atopic dermatitis, sensitization of aeroallergens or foods, blood eosinophilia, and increased IgE levels, or wheezing not associated with upper respiratory tract illness. The Modified Asthma Predictive Index can be used to help with asthma diagnosis and is recommended by the National Institute of Health guidelines. Confirmation of the diagnosis of asthma relies on the pulmonary function testing using spirometry, which can be accomplished only after the child is 5 to 6 years of age. Characteristic abnormalities of spirometry testing would be reduced flow rates that are reversible in response to an inhaled bronchodilator. For younger children, an empirical trial of asthma medications is commonly initiated. Many children with less severe asthma outgrow the disease by adulthood and may reflect a particular genetic phenotype of asthma. The goal of asthma therapy is to achieve long-term control by reduction in impairment at risk. Child and family education and appropriate allergen avoidance techniques should begin immediately. Care providers must periodically assess asthma control in children. Key features for assessment include nighttime awakenings, interference with normal activities, use of short-acting beta-2 agonists, pulmonary function testing, and exacerbations requiring corticosteroids. Peak flowmeters are often used to help guide treatment. Before therapy is augmented, care providers need to assess medication administration techniques, environmental controls, and comorbidities. Stepwise reduction and therapy can begin after the child's asthma has been well controlled for a minimum of 3 months. The pharmacologic treatment of asthma in children is essentially the same as for adults and is initiated in stepwise sequence based on asthma severity and response to treatment. Management of asthma medications in children is often difficult because there is commonly fluctuation in severity and symptoms. Your acute lung injury, acute respiratory distress syndrome, occurs in children of all ages and is a dramatic, life-threatening condition resulting from a direct acute lung injury, or ALI, such as pneumonia, aspiration, near drowning, or smoke inhalation, or from a systemic insult, such as sepsis or a multiple trauma. ALI, or acute lung injury, activates an inflammatory response that causes alveolar capillary injury and results in ARDS, that acute respiratory distress syndrome. ARDS accounts for approximately 10% of total admissions to pediatric intensive care units. Mortality in pediatrics varies from 18 to 35%. The pathophysiology of ARDS is similar to that of adults. However, our clinical manifestations, according to the Pediatric Acute Lung Injury Consensus Conference, has developed a definition for pediatric ARDS, or PARDS, that has some elemental differences. All pediatric age groups are affected from the neonatal period through adolescence. The perinatal causes of acute hypoxemia are excluded. Your lung disease related to prematurity, perinatal lung injury, that meconium aspirated syndrome, pneumonia and sepsis acquired during delivery, and congenital abnormalities, congenital diaphragmatic hernia and alveolar capillary dysplasia. The onset of hypoxemia and the radiologic changes that occurs 7 days after the known clinical insult. The chest radiographics show new infiltrates, either unilateral or bilateral, consistent with a parenchymal lung disease. Children with left ventricular dysfunction presenting with acute onset hypoxemia and new changes on chest radiographs not explained by left ventricular failure or fluid overload, and who meet all other PARDS critical or criteria are included in the definition. And then lastly, the degree of hypoxemia, used to define the severity of PARDS, uses the oxygenation index OI, which equals the mean airway pressure, and there is a calculation to that, rather than the PaO2-FiO2 ratio. In the event of the PaO2 is unavailable, the oxygenation saturation index can be used under the same condition. Initially, hyperventilation occurs, but CO2 retention may ultimately develop because of inadequate functional airspace. Atelectasis, decreased pulmonary compliance, and a respiratory muscle fatigue. The severity of the overall picture is modified by comorbid factors, such as the presence of sepsis and multisystem organ failure, and the development of complications, such as nosocomial pneumonia. More research is needed regarding the long-term outcomes of pediatric ARDS. The evaluation and treatment of ARDS in older children and adolescents is similar to that in adults. However, infants who have more compliant chest wall, lower hematocrit levels, higher baseline airway resistance, and lower functional residual capacity. The maturing lung may be at greater risk for ventilator-induced lung injury. These factors have implications for management strategies that are different than those for older children and adolescents. Few randomized controlled trials have been completed to guide the clinical management of ALI-ARDS in infants and very young children. Treatment of ARDS remains supportive in nature, including maintenance of fluid balance and nutrition. The goals of therapy are to maintain adequate tissue oxygenation, minimize acute lung injury, and avoid iatrogenic pulmonary complications. Most children with ARDS require mechanical ventilation and relatively high levels of positive end expiratory pressure, that PEEP, to promote alveolar ventilation and stabilization and redistribution of alveolar edema into the interstitium. Lung protective ventilation strategies may include low tidal volume, permissive hypercapnia, permissive hypoxemia to prevent oxygen toxicity, and airway pressure release ventilation. The use of corticosteroids in children with ARDS is controversial. One study reported fewer ventilator-free days and longer duration of ventilation in survivors. Extracorporeal membrane oxygen (ECMO) is used for reversible causes of pediatric ARDS and considers quality of life. Cystic fibrosis is an autosomal recessive inherited disease that results from defective epithelial chloride ion transport. Cystic fibrosis gene is located on chromosome 7, and more than 2,000 different variants of this gene are known to produce cystic fibrosis. They are divided into 6 classes with varying severity of disease expression. Classes 1 through 3 are associated with more severe disease, and classes 4 through 6 with milder pulmonary disease. Mortality correlates respectively with the aforementioned classes, and therapy is currently being directed at a specific gene class. The incidence varies by race and is higher in whites. Approximately 28,680 individuals in the US and 70,000 worldwide manifest the disease. In the US, approximately 853 new cases of CF were diagnosed in 2015. The median age at diagnosis was 4 months, and more than half of the CF population was age 18 or older. The median predicted age of death was 30.1 years of life. So what is the pathophys? Well, CF is a multi-organ disease that affects the airways, digestive tract, and reproductive organs. Cystic fibrosis transmembrane conductance regulator, your CFT-CR gene, mutation results in the abnormal expression of cystic fibrosis transmembrane conductance regulator protein. There are many CFTR variants, and they are grouped into 6 classes. The most common mutation is called the F508del CFTR. The CFT-CR protein is an activated chloride channel present on the surface of many types of epithelial cells, including those lining the airways, bile ducts, the pancreas, spit glands, the paranasal sinuses, and the vas deferens. The most important effect are on the lungs, and respiratory failure is almost always the cause of death. The typical features of CF lung disease are mucus plugging, chronic inflammation, and chronic infection of the small airways. The mucus plugging results from increased production of mucus from increased number of size of goblet cells, altered physiochemical properties of the mucus and impaired mucociliary clearance. CF mucus is dehydrated and viscous because of its defective chloride secretion and excess sodium absorption. The periciliary fluid layer is depleted in volume, impairing the mobility of the cilia and thereby allowing mucus to adhere to the airway. Epithelium along with bacteria and injurious byproducts from the neutrophils. Neutrophils are present in the great excess in the airway and release damaging oxidants and proteases that cause direct damage to the lung structural proteins, resulting in remodeling of the airway and ultimately development of bronchiectasis. Neutrophils promote inflammation and induce airway cells to produce interleukin-8, which attracts more neutrophils and stimulates mucus secretion and destroys the immunoglobulin G, that IgG, and complement components important for opsonization and phagocytosis of pathogens. Bacteria then form biofilms promoting chronic endobronchial infection. Progressive bronchiectasis becomes widespread. Parenchymal involvement occurs much later and includes microabscess formation, patchy consolidation, and pneumonia, peribronchial fibrosis, and cyst formation. The pathophysiology for these changes is outlined in Figure 3715. Airway obstruction and weakening of the airway wall can lead to the development of the peripheral bullae, which may rupture and cause a pneumothorax. Hemoptysis, sometimes life-threatening, may occur because of erosion of enlarged bronchial arteries that develop in the response to the inflammation associated with bronchiectasis. Over a long period of time, pulmonary vascular remodeling occurs because of the localized hypoxia and arteriolar vasoconstriction. Pulmonary hypertension and cor pulmonale may develop with end-stage disease. So if we have our CFTR gene mutation, there's a decrease in chloride secretion and ion transport that causes an increased water absorption and impaired ciliary function. That dehydrated mucus then causes impaired mucus clearance in the airway, which triggers a chronic bacterial infection eventually, and chronic neutrophilic inflammation. That inflammation causes that bronchiectasis, which leads to respiratory failure. Clinical manifestations. Well, the most common manifestations involve the respiratory and gastrointestinal system. Respiratory symptoms include persistent cough or wheeze, excessive sputum production, and recurrent or severe pneumonia. More subtle respiratory tract presentations of CF include chronic sinusitis and nasal polyps. Digital clubbing may appear quite early, even in the absence of significant pulmonary impairment. Development of the barrel chest or persistent crackles occurs much later in the course of the disease. The overall severity of CF lung disease is highly variable. Even affected siblings may have disparate courses of different clinical phenotypes, despite identical CFTR mutations, environment, and treatment strategy. The CFTR genotype is expressed differently in epithelial cells of different organs. Airways, sinuses, the GI tract, pancreas, biliary system, sweat glands, and genitourinary system, and results in phenotypic variation in clinical manifestations with influences on disease progression and survival. So, evaluation and treatment. According to the Cystic Fibrosis Foundation, guidelines for the diagnosis of CF include one or more clinical features. History of CF in a sibling or a positive newborn screen plus lab evidence of an abnormality in the CFTR gene or protein. A standard lab method of diagnosing or screening are the immunoreactive trypsinogen IRT blood test and the sweat chloride test, which reveals sweat chloride concentration in excess of 60 MEq per liter. Alternative or supplemental methods include genotyping for CFTR mutations. Newborn screening for CF is universal in the US. Genetic counseling for CF gene carriers is important so they understand the risk assessment in relation to the disease. Treatment is primarily focused on pulmonary health and nutrition. Because the pulmonary decline in CF is slow and insidious, and because of the early onset of chronic inflammation and infection, treatment strategies begin immediately at diagnosis and are modified over time as disease progresses. Pulmonary therapies include techniques to promote mucus clearance, such as chest physical therapy and related mechanical devices, and an assortment of handheld positive expiratory pressure (PEP) devices. Aerosol therapy includes bronchodilators, Dornase alpha, and hypertonic saline, which liquefy mucus. Different classes of antibiotics and routes of administration, whether oral, inhaled, or IV, are used to treat the different pathogens and to overcome antibiotic resistance. Targeted therapy with oral CFTR modulators is available to treat specific CFTR mutation dysfunction. Ivacaftor has been approved in the US, Canada, Australia, and the EU for individuals 2 of age and older. For the G551D CFTR jading mutation, the corrector potentiator pair, the lumacaftor ivacaftor, has been approved in the US for individuals 12 of age and older who are homozygous of the CFTR mutation, the F508del. The drugs are effective in lung, GI tract, and spit glands, but are very expensive. Further research is in progress to target the other common genotypes. Recombinant human growth hormone has been shown to improve lung function, height, and weight in children with severe CF. Azithromycin, ibuprofen, and corticosteroids can reduce airway inflammation and improve lung function. New anti-inflammatory drugs are under investigation. Individuals with end-stage lung disease may consider lung transplants. Nutritional problems are extremely common in CF, and poor nutrition is correlated with worse outcomes, including progression of lung disease, onset of additional complications such as a decreased bone mineral density, and growth failure. Elements of aggressive nutritional support include meticulous monitoring and growth parameters, controlling fat malabsorption, maintaining adequate protein and caloric intake, and keeping overall health stable. Approximately 90% of children with CF have pancreatic insufficiency. This is the result of an abnormal ion transport, causing decreased fluid and bicarbonate secretion from the pancreatic acinar cells, which leads to the thickening or thickened secretions plugging the smaller pancreatic ducts and eventual autodigestion or atrophy of the acinar cells. Therefore, individuals must take exogenous pancreatic enzymes with meals and snacks in order to absorb nutrients and control malabsorptive symptoms. Diabetes can develop as a secondary complication of pancreatic involvement. There is a growing contingent of adults with CF living into their 40s and 50s. Care for these individuals shifts away from the pediatric focus because their care needs are unique and often extremely complex. Pregnancy also has become possible with advances in vitro fertilization for men and women with fertility problems. And that leads us to the sudden infant death syndrome. SIDS remains a disease of an unknown cause and is the most common cause of an unexplained infant death in Western countries. It is defined as sudden death of an infant under the age of 1, which remains unexplained after a thorough case investigation, including performance of a complete autopsy, the examination of the death scene, and review of the clinical history. Incidence of SIDS is low during the first month of life, but sharply increases in the second month of life and peaks at 2 to 4 months, and is unusual after 6 months of age. In 2014, about 35,000 infants died of sudden unexpected death in the US, of which 1,500 were attributed to SIDS. Other causes were accidental suffocation and strangulation in the bed, and others were unknown. SIDS is more common among non-Hispanic blacks and American Indian Alaska natives. It almost always occurs during nighttime sleep, when infants are least likely to be observed. A seasonal variation has been noted, with higher frequencies during winter months. This has been related to the higher rate of respiratory tract infection during those months. And infections are often reported to have preceded the death. The sleeping room also may be overheated or the infant overwrapped. Clinical risk groups have summarized in 37.3. About 75% of all SIDS victims have no known predisposing clinical factor. The epidemiologic studies have shown that SIDS rates decreased where massive public campaigns warned against prone sleeping for infants. The etiology of SIDS remains unknown, but probably involves a combination of predisposing factors, including a vulnerable infant in a critical developmental period of homeostatic control, with altered cardiorespiratory, circulatory, and arousal characteristics, and environmental stressors. Again, prone or side resting position, soft bedding, or in utero or environmental tobacco exposure. There has been long-standing interest in the hypothesis involving impaired autonomic regulation and failure of cardiovascular, ventilatory, and arousal responses. Other theories involve immune dysregulation, airway inflammation, and responses to either bacterial pathogens from the nasopharynx or viral respiratory tract infections. Finally, there is a growing evidence that genetic factors may predispose certain individuals to SIDS. The most important risk factors genes include those involved in the regulation of the immune system, anti-inflammation, cardiac function, and brainstem function. Currently, the best strategy to reduce SIDS and sudden unexpected infant death occurring during sleep is avoidance of risk factors as described by the American Academy of Pediatrics. Breastfeeding has been identified as a specific risk reduction measure. Parents of infants with clinical risk should be taught cardiopulmonary resuscitation as a precaution. Some infants at risk for episodes of apnea and bradycardia may warrant cardiorespiratory monitoring after careful consideration of the individual situation. And that completes our chapter here. So I will get to our next reading chapter in just a moment, and we'll jump right into further chapters. So I thank you for watching, for being part of the stream, and I shall see you next time. Till then, thank you, and have a wonderful evening.